Thanks everyone for joining us today. I think we're going to be having a fantastic experience today and really appreciate you coming here on break and giving up your time today. Just shows that you're very dedicated about what it is that you're studying and what you're learning, so that's absolutely fantastic. My name's Claire Langdon. I'm the Professor and Director of the ECU Health Simulation Centre here at Edith Cowan University, and I head up a team of fantastic people who bring reality to life for us. So these are our topics. So we're going to be talking about what's a good death, talking about some of the cultural considerations in end-of-life care, how to have difficult conversations and how to break bad news. We've got a guest speaker coming to talk to us about advanced care directives, advanced care planning. Then we're going to be delivering bad news, which is a live acted simulation. After lunch we'll be going further into advanced care planning and advanced directives. We'll be coming back in for another live acted simulation on end of life. And then we've got some fantastic people from the palliative care team at one of the tertiary hospitals who are going to be coming in to talk to you about their roles and running you through some of the things that they do. So they're a really great team. Pretty full day. Yeah, it's a pretty emotional day as well. So I think it's important to note that you might have some feelings that come up during the course of the day that might be a bit confronting for you. Certainly as someone that's worked in health professional roles for a number of years, end-of-life care, and the reason we're having this workshop is because it's really tough stuff. So even people that deal with end-of-life issues as part of their normal work find it very difficult. I mean, it's never going to be easy to have these sorts of conversations, and it can be very, very emotional stuff. So do be prepared that it's a bit of an emotional journey that we're going on today. But I think it's kudos to all of you because you've made the commitment to come in today and to explore these issues with us as part of preparing yourselves to be the best healthcare professionals that you can. So well done. There's contact details for counselling on the screen for anyone that feels that they are getting some things that they'd like to talk about, and those are free services. Okay, now a little bit of ground rules for you. This is what we believe, that everyone that comes today cares about what they do, that you're all intelligent, you care about the profession that you're choosing as part of your studies, and that you want to improve. So I think that's a really important underlying thing to keep in mind. The other thing is your insights and questions are going to inform everybody, so be heard. Okay, so we'll kick off and start with getting people's thoughts on what it is that constitutes a good death. It's a strange expression, isn't it? Yeah. Who in the room has had experience of death? Now, it used to be that people, when they died at home. Is that still true?
My mother died at Royal Perth Hospital, but we had the whole family around, and she had time to prepare, and we had time to prepare for her death. And so I'd say that's something that contributes to a good death, is the time to prepare and having everyone around. And also she had time to say goodbye to, I think, practically everyone. So we felt peaceful in that way. That was really important for us. Yeah.
Thank you. And she died in the hospital setting?
In the hospital, yeah.
Yeah. Would that have been her choice?
She'd been going through chemotherapy, and we would have probably normally thought that she would have wanted to die at home, but towards the end she realised, I think, that she needed more care, more medical care and nurses' help. And so she'd gone in for the last lot of chemo, and then she started, well, it wasn't expected, but she went downhill very quickly. And we were trying to sort of say, oh, how can we get you back home? And she said, no, I want to stay here. And so I think, remembering back, it was quite a long time ago, for a moment I was taken back because I realised she wasn't going to go home. But it was good. It was fun. Yeah. It was fine that she stayed in hospital.
Yeah. Thank you. Yeah. Even quite obviously some time after the fact, it's obviously still a very emotional thing. Yeah. So we do thank you for sharing that. That's really, really brilliant. Yep.
I had a similar, my mum died a long time ago, and we weren't, it was long and arduous, and she did have time, and that was one of the great things, that she had time to say goodbye while she was still around, and a lot went on there, but she did die at home, and we were so lucky to have able to have nurses, and there was a hospice nurse that was a neighbor, so she was around. So, but I know that she would have, wherever she was, it would have been okay at that point, past a certain point. But she was able to die at home, 1984. So that was a good. Way back then, it was still going on.
So you'd had time to prepare?
Yeah, she did. She did everything. She decided what was going to happen pretty much. But then even if she would have had to go in and that would have happened, she would have been at peace with that too. It's sort of like when it gets past a certain point, or my experience was, both my parents had that peace that they were able to choose where in the moment too. So that was pretty cool.
That's excellent. And up the back?
I used to work at Charlie's on the haematology oncology ward, and I spent 12 months there. So we used to do a lot of palliative care, and a good death for us was making sure that the family had all their meds need. It wasn't, the palliative care time wasn't for the patient as such, it was for the family to make sure they spiritually had what they needed to move on, and stuff like that.
And I think that's bringing up a really important point. You might be familiar with the work of a lady named Kubler-Ross, who talks about the stages of death and dying. Her work came, I think, from the 60s, so it's quite a long time ago, but she talked about the stages of grief that happen. So the first thing that tends to happen is that you have shock and disbelief, and move through the stages of anger and bargaining, and slowly move to the stage of acceptance. And I think for some people, being able to reach that acceptance is very important. So here's another question for the room. Is death the worst outcome?
I've had a lot of patients who have obviously been ready to die because they've been unwell or old and ready to go, but their families prolong it a lot longer than need be, I guess, for their, I don't know if I want to say selfish, but for their own sort of needs, and they're asking to be let go but aren't able to, and I think that takes away from them having a good death. Maybe it makes it better for the people who sort of stay here afterwards, but sometimes it's so hard to just watch these people and they do want to go home, or they just want to stop taking all these meds and having all these fluids and nasogastric tubes and all this stuff happening to them, and they're ready to go, but everyone else around them won't let them. That's quite, I think that's worse than dying for a lot of people. Yeah.
I was just going to say, just following on from that, I've actually had the opposite, where we've had families arrive expecting their loved ones to have passed on, and then they haven't. And I mean, I didn't know how to take it the first time she came in. It was quite comical, and she came in and she said, "Oh, he's still here. This is horrible." Like, she went down to the coffee shop and she'd come back, and every time she came back to the ward, she'd be, "Oh, he's still here. Well, I've got a holiday in a couple of days." And so her grief had obviously been different, because she'd obviously had moved on, but didn't want him to come home. He wanted to die in the home. So it's, I mean, following on from that, a good death for her would have been quick for her. So everybody's, but yeah, obviously her grief pattern was faster than, so.
So she certainly worked through those stages.
Yeah, and it was quite a challenge for us as health professionals coming in every day and having to, we would be expecting to put our arm around her and make sure she was okay, but she was quite okay and had moved on quite quickly. So everybody's sort of different in the pace that they do it.
And that raises a really interesting point in that some people will move through the stages and then go back to another stage. So you might think that someone's moving towards acceptance and then be encountering anger again. Yeah, so.
I was just thinking about the question, is death the worst thing? With my mum, and this was 1990, so it is a long time ago, when she got her diagnosis, she was told she had probably 2 to 5 years before she would die, and she started chemo straight away. And then actually she went downhill very quickly and she died within 7 weeks. But she tried so hard and everyone did the best they could. But because it was so difficult at the end, we actually were really relieved for her, and we thought that death was the better thing for her because we thought, oh my goodness, if she'd had to go through that for 2 to 5 years, that would have been so much worse for her and for us, So death was we thought the better thing, and we were really peaceful about that, to have gone through that with her and see the process. That helped us to accept it, because we'd seen her suffer.
So my grandma died of cancer about 4 years ago, and she got told a year, and she went on chemotherapy by a young doctor, told her that you have no reason, you're gonna die, so let's prolong it. And I wish she didn't, because her quality of life was less. And she used to be a hairdresser, and so when her hair started falling out, it was heartache to her, so she shaved it off. And she couldn't do the things she normally would do. She liked knitting, she liked doing things that she would always used to do. She used to do her gardening. And so her quality of life, she lived another 3 years after that, being diagnosed, and every time I saw her, she got worse, and her mental state started decaying, and because she started giving up hope. And so I personally think a good death is one where we don't prolong it, because she was ready by the year mark, and then she kept getting good and then get bad again. She had all these peaks, and I think that's bad for the family as well, because my pop kept saying, oh, she's getting better, and then you go, oh, she's getting worse, and then it was just a very emotional experience. So I think a good death is when it's not prolonged. And I actually wish that she didn't actually live that long, because it was harder for the family, and the funeral came, it was much heartbreak, because she was actually doing good before she died, and she had a turn, and in the space of a week before she was walking, and then in the space of a week she was in hospital in a coma, and that was very emotional for her family and ours, and it was just, I think a good death is not being prolonged. Yeah.
I think a good death is very personal to the person that is actually about to pass away, as well as possibly polar opposite for their family. My dad died very suddenly. He was in a coma, and it was put to my mum to give him possibly an operation that could have prolonged his life, and it wasn't really a question, it was this is what we're going to do for him. He had a brain tumour, and the surgeon left the room, and my mum thought about it and asked him to come back and said, look, will his quality of life be the same? And he was like, oh, no way, he can forget the golf, he can forget playing with his grandchildren. And my mum made the decision to not have the surgery, because she was like, of course I want him around, but I know he won't want to be around in this state, because she was like, I wish nothing worse than sitting there and him looking at me being unable to communicate, but being so angry with me for doing it to him. So she made that decision, which I think was the better decision, but she has a mental tug of war with herself all the time, I think, wondering, because he died, I actually think it was taken out of her hands. He had a stroke very soon after that conversation, so I don't think it would have come around anyway. But yeah, I think it's being selfish and wanting to hang on to them, but doing what's best for the person that's about to pass away. My dad wouldn't want it to live like that, so she made that decision for him, I suppose.
It's a pretty brave decision.
It was a very brave decision, yes.
In the package of pre-readings that we sent out, there was an article, Doctors Die Differently. Yeah. What are your thoughts on that, where doctors actually don't choose life-prolonging measures?
So my opinion, I think because doctors, they obviously deal with it nearly on a day-to-day basis, and they help the families go through that process of coming to terms with what's actually going to happen, that when it comes to their time, they don't want their family to have to make those decisions and have to feel what they experience on a daily basis. So they take, I guess what we'd say is the easy way and just make it as easy and quick as possible to help everybody, because they know what happens before and after, and it's just their way of dealing with it. I mean, doctors have to be basically a vault a lot of the time. So if you could imagine getting to the end of your life with all this emotional baggage, I guess, you just want to make it quick and as easy as possible for everyone around, so that, you know, it's just over with and no one has to deal with that kind of thing again.
A lot of the doctors I used to work with used to say they always had advanced health directives because they hate to put their families in the position of making a decision, as a decision that they see many families make a day, and it was just so hard for them to watch that they figured they'd take it out of anyone else's hands, and they all have advanced health directives at Charlie's.
Okay. I know from my own personal experience, when my father died, he'd had quite a number of strokes, and he was quite an organised person, so he had gone off and he'd prepaid his funeral, and he'd left quite a lot of directives about what he wanted and what he didn't want. So he certainly didn't want flowers, he hated flowers, didn't want those at the funeral. So the only thing that was really left for myself and my mother, who I suspect had early dementia at the time, was to go in and just tidy up the arrangements to make sure that we were dealing with what it was that he wanted. And we had to choose the music to be played at the funeral. And Mum decided that she wanted to have Harry Seacombe. I don't know if you know Harry Seacombe, he's sort of very popular back in the 50s and 60s. She wanted to have Harry Seacombe singing, and I said, oh, gee, that's interesting, Mum. I didn't know Dad liked Harry Seacombe. She said, oh no, he didn't, he hated him. So that one thing that the poor man had left to chance. Yeah. We had Harry Seacombe. It was easier just to let that one go. Okay, so certainly when people have researched, they've come up with the following that people who are at the end of life thought was important to them. So one thing is freedom from pain, being at peace with God or spiritual belief, presence of family. So certainly most people that work in health will tell stories of someone who is dying and is actively dying, but there's a family member that's coming to say goodbye from interstate, overseas, whatever, and these people will actually hold on until that family member arrives. Being mentally aware, having their treatment choices followed, having their finances in order, so not having to worry about funding. Is there any thoughts on those?
Another one that's quite common is waiting for their family members to leave. They want to do it when they're alone, and so their family don't watch. It's actually quite common. You'll ask the family to step out so you can give them a wash or you can do anything like that, and then they'll go, and it's like they know they've left the room and they're not watching, and it's something different that you see quite often.
So you had some very profound experiences up there at Charlie's.
Yeah.
Do you feel like that changed your nursing practice? I'm assuming it was nursing.
Yeah. My nursing changed forever. Like, it's the most magical thing to do is to hold someone or tell their family you're going to be all right when they're gone, or different kind of beliefs, Indigenous people, all of those things, helping them get through their stages, because a lot of the time it's a lot different and they don't move from the bed at all. Had a great elder, and she literally didn't leave the bed until he passed away. And that was like 24 hours of not being. We were all like, seriously, you need to go to the bathroom. I'll sit here while you go. And she said, no. She sat there for 24 hours and didn't move from this person. But it shapes your nursing, and it's a fantastic skill to have, to be able to talk to someone or just hold them or just be there for them.
Sorry. I was going to say, I've only had 4 weeks experience in palliative care, so not the same, but it's the same for me in the sense that it was the art of nursing. We seem to have a bit of a task-orientated, we have to balance that task-orientated with our therapeutic care, and I really liked the palliative care area because I had that extra little bit of time to spend with someone, and it didn't have to be anything greatly poetic or anything. I didn't say a lot, I listened a lot, and I just held their hand, and it was things like getting family members a cup of tea, and they might not have had anything to drink, and you left that day feeling really good that something so simple, and that's the skills that, you know, we probably all came to this profession to do that art of caring, rather than saying, oh, today I have to tick off check. So I really enjoyed that experience, and it's probably an area that I'd like to go into post-grad. So.
And what I'm hearing is that, you know, it can be a real honour to be able to do that service for someone at that part of their life journey.
I just want to acknowledge the nursing staff, because as a family on the receiving end, we really appreciated the nursing that Mum received. And I remember the young nurse, she would have only, she was a young lady, and Mum really appreciated the care that she gave her as well, and like that final sort of sponge down or bath, whatever it was, and we all left the room. And I mean, we were privileged to be with her when she did actually die, but the care that she received and the bond that we could see that she formed with that lady, who she really, I think she only, that last shift was the first time that nurse was with her, because I don't think she'd been there in the days before. You know, she probably was off. But that was really very special for us, the nursing care, and simple but so profound. Yeah.
And it's certainly not unusual for nurses and care staff to become quite emotional when somebody passes, even if it's not their family member. And I think that's one of the wonderful gifts that you can give the family, is showing that even in the brief time you knew their family member, that they were a valued person and that they meant something to you. So thank you, it's been a really terrific start, and thank you for those of you that shared their insights. Okay, so cultural considerations. Australia's a very multicultural society now, so what are some considerations for people from another culture? Is there anyone in the room who's from another culture that can share their cultural beliefs around the end of life? Yes, please. Thank you.
Well, I guess that for my faith, for Muslims, we have sort of like a process after death. So I guess it's like a spiritual kind of wash, and then and Muslims mostly believe like it's a soul, not really the body. So like the fear of like the body, it's like over. It's more of the soul, like it's going now. There's a prayer as well, and so it would probably be like a very spiritual time for a family, because we believe the soul is going on to the next life and to the grave. Yeah, yes.
So what would be the best thing that as health professionals we can do for a Muslim family at the end of life?
I guess like some space. I haven't like dealt with that yet, my family, but if someone in my family were, God forbid, to pass away, I guess I would just want some space and some like understanding, because we would like the body to be handed over as fast as possible, because we want it to be, the process to take place quite fast, because the body needs to go to the grave, I guess. And yeah, so that space and that understanding that like things need to be a bit faster, like, you know, any documentation or anything that needs to take place, just speed it up a bit so that we can take over. Because yeah, Muslim families usually take over after death, so the body will be handed over to the family.
And is there a particular time period before the body's interred?
Different kind of groups have different like understandings. I guess it's usually 24 hours or sunrise sometimes or sunset.
So that time factor is really important.
Yeah, really important.
Thank you for sharing that. Anybody else from a... Oh.
It's really important to have the discussion before their loved one has passed. Ask, are there any religious beliefs, so that you're pre-warned, because I think it's Jewish where once a person has passed away you can't touch the body at all. It has to be blessed and everything first before anybody can touch it. So it's really important to know what your steps are. So you've got in your head, okay, the person's passed, I can't touch them, but I need to contact this person, or something like that is very important for the family members. And asking them, because they will be so grateful that you've asked what their beliefs are, or do they need a priest to come and bless the body or give the final rites, or any of those things which mean so much to them.
It certainly shows respect, yeah.
Yeah. It's giving them the dignity.
The point that you raise about feeling empowered to actually ask is really important, because if it's a culture that you're not familiar with, and there might be something that is going to impact on the way that you can deliver care at the end of life, then it would be really important to say, look, I'm sorry, I don't know much about your culture. Are there any factors that are important to you that I need to be aware of in providing the best possible care to this person? Okay. What about our filters? Our filters are our beliefs, our baggage, the things that can stop us being able to interact well with someone from another culture. I think we do need to be aware that we all carry our own filters and our own beliefs, and in some cases that can colour how we deliver care. So we heard about an Indigenous elder who stayed put for 24 hours, which was pretty impressive. But I'm going to show you a resource, if I can get the technology to work, for Indigenous culture. Wish me luck. Yep.
Hello.
Morning.
Has Mr. Barry had any family visit?
No, he's up from Port Hedland way, so he doesn't have any extended family down here.
Well, that's going to be hard on him. Yeah. Has anyone been to see him from Aboriginal Liaison?
Yeah, Mick Williams from Aboriginal Liaison came in a few days after he was admitted, but he was still quite confused. I can give Mick another call.
Yeah, I think that would be a good idea.
Yeah, I have to check it's okay with Mr. Barry first. But...
Yeah. Has he been reviewed by the consultant this morning?
Yeah. Yeah. Dr. Owen has confirmed the case meeting for Mr. Barry on Wednesday morning. And Dr. Fox, who referred him from Port Hedland, will be present on conference call.
Great. And will the Aboriginal Liaison Officer be at the meeting?
Oh, yeah, I'd say so, but I'll check with Mick when he comes in.
It'll be good to discuss his care with the whole team.
Yeah, absolutely.
Yeah.
You right there, Uncle? You remember me? I visited you a couple of days ago. Your nurse Carrie here gave me a call. He's might be worried about you. You mind if I sit down and have a yarn with you? So how you been, Uncle?
No good. This place no good.
You got any family down here, Uncle?
All my banyama. Port Edland mob.
Yeah.
Where are you from?
I'm from here, Perth. I'm a Nyunga man. My tribe is Ewart tribe, from Moraway, you know? Yeah.
Not my place here.
Yeah.
Too many fellas telling me what to do. Where I come from, I get treated with respect.
Mr. Barry is a respected elder in his community. He's away from his people and his way of life. I'm sure everyone here is just trying to help him, but Aboriginal health is about all aspects of their life. You have to listen deeply and resist the urge to just give solutions.
Did you catch them a lot?
Yeah, you can.
Thanks for coming today. I appreciate you juggling your schedules to be here. How are we going, Kerry?
Hello? Aha, here we go.
Hello, Peter. Thank you for joining us today.
Thanks for involving me early on.
I'd like to introduce you to some of our team. Kerry Scotter, a clinical nurse.
Hello, Peter.
Annie Moore, physiotherapist.
Hello.
Lou Anderson, dietitian.
Hello.
And Mick Williams from Aboriginal Liaison.
G'day, Peter.
Hi, everyone.
Peter, as you know, we're meeting today to discuss Mr. Jack Barry, a 50-year-old Aboriginal male patient you referred to us from a community out of Port Hedland. Okay, let me recap Mr. Barry's history. He was admitted a week ago with end-stage renal failure and hypoglycemia. He has type 2 diabetes, glaucoma, pulmonary edema, anemia, and left ventricular hypertrophy.
How's he going now?
He was initially on BiPAP, and his breathing has now improved. He's had dialysis this week and responding reasonably well.
Oh, that's good. He was pretty confused when he came to Port Hedland last week.
Oh, he's lucid now. His U's and E's are looking better. His hematocrit is up. His creatinine and his blood sugar have stabilised. His potassium is corrected and he's off monitoring.
Ah, awesome.
Kerry, could you brief the team about his progress?
Thanks, Richard. He's still very lethargic and generally feeling unwell. He says the itchiness of his skin has improved and he isn't requiring as much pain relief for the headaches. His appetite is still down and he's suffering from nausea. The Maxilon before meals has helped a bit, but I'll let Lou discuss that further. He's on an 800ml fluid restriction plus previous day's output. Got some of his charts.
So what does that mean?
Sorry, Mick. So if, for example, Mr. Barry passes 100 mils of urine the previous day, he can have 900 mils to drink the following day. So there's an 800ml fluid restriction plus an extra 100 mils.
Oh, okay.
How's he tolerating this?
I thought he was tolerating it fairly well. Sometimes it's hard to maintain a fluid restriction. If we're busy, as we often are, we have to go by what the patient tells us. Look, Jack, I know it's hard, but you can't have any more to drink today. Okay? It's bad for your kidneys.
I'm thirsty.
I know, I understand that.
I'm thirsty all the
I
time.
know, we're just going to get you back to bed. Okay, so we're just going to move backwards. Sit nice and slowly. There you go. There you go. That's it. Thanks, Susie. Jack, I know it's hard, but your doctor and I spoke to you about how much fluid you can have. There is a reason for it. If you drink too much, you'll just get sicker. Okay, it's bad for your heart and it's bad for your blood pressure. Since you're up, do you want me to take you to the shower? Okay.
All right, we'll get you back in there. That's it. Lift up your legs, okay? That's it. That's it.
We are trying to help him space his fluids throughout the day. We're giving him ice chips to suck when he's thirsty, and we're giving him regular mouth care.
Kerry, when he got out of bed to have a drink, how was he on his feet?
Quite weak. He had to hold onto the sink, and I had to assist him back to bed.
Yeah, I've noticed his range of movement is deteriorating and he's very lethargic.
He's refusing to get out of bed to have a shower. Any idea how I can help him with that, Mick?
Well, he may feel offended when you ask him to have a shower. He may think you think he's dirty.
I didn't even think of that.
And also, he's an elder in his community. So having a young female help him isn't really appropriate in his law or his culture. Maybe if a male nurse offered to help him.
Yeah, that makes sense.
It does. Perhaps that's the reason I found it difficult to mobilise him. Mr. Barry, how about you have a go at getting up to walk today?
Leave me alone.
It doesn't take much time for muscles to get weak when they're not being used. If you strengthen your muscles, you'll be able to keep doing things for yourself, and the swelling in your feet and legs will improve.
I'm too tired.
Perhaps we could try some passive or gentle leg exercises today. He seems uncomfortable when I try to work with him. Do you think he'd prefer to work with a male physiotherapist?
Yeah, I reckon.
Okay, I'll have a talk to my colleague Mark Ryan about taking over his care. Thanks, Nick.
Yep. Good. Kerry, how's his weight going?
His weight is down 5 kilograms. He's just not interested in any of his meals.
I agree with Kerry. His nutrient intake is inadequate. I've calculated his nutritional requirements and educated him about his renal diet on several occasions, and the nurses have started a food chart so we can monitor his intake. I just wish I could help him understand how much his diet could improve his health. You're not hungry? I know the renal diet can be pretty bland and there are a lot of things you can't eat.
It's not what I eat back home.
Oh, I understand it must be very different to what you're used to.
No good. This food no good.
If you try and follow the diet I've given you, it'll make you feel a lot better. It'll help bring your blood pressure down and reduce your need for medication.
I don't want none.
We may need to consider dietary supplements and, if necessary, tube feeding to meet his protein and energy requirements.
I may be able to suggest some bush tucker that's still okay for his diet, Lou.
Yeah, there might be something I've overlooked. Perhaps we could grab some time to discuss it with him.
Yep, sounds good. If they look at things from Mr. Barry's perspective, then maybe his behaviour will be more understandable.
People here, they talk to me about why they do stuff. I don't understand a lot of their words. They don't give me enough time to think it through. They come in here with trolleys and tubes and sticking things in there.
Hey, do you understand why you're having this treatment?
Yeah, a little bit.
Yeah.
Doctor told me it's for my kidneys. They give me this dialysis.
Yeah.
I get dialysis. And that lady who told me what to eat, she's a dietitian. Hey, there's a whole lot of dying going on around here.
Hey, Unc, do you want me to ask the nurse to come over and have a yarn with us? Because I understand a little bit about this dialysis, but it's not really my place to tell you. Because I might say the wrong thing, you know? Kerry, do you mind if we have a yarn with you?
Yeah, just give me a minute. Sodium chloride, May 2013. How can I help?
Unc doesn't really understand the dialysis he's having.
Mhm.
Would you mind explaining it to him again? You know, like why he's having it and why he needs it?
Yeah, sure. Well, Jack's kidneys aren't working properly anymore, so... Sorry, Jack. Dialysis does the work of the kidneys. So it's going to clean your blood.
So the toxins, the poisons, they don't build up in your body.
What'd she say?
So your kidneys are full of rubbish and the machine cleans it all out for you.
That's right. If you don't have dialysis, then your kidneys will stop working for good. So your blood pressure will get higher, and the blood vessels in your kidneys, they'll get very skinny, very hard, and your kidneys won't get enough blood. But kidney failure doesn't mean you can't have a good life. Dialysis, the right diet, exercise, makes life a lot better, and you can live a long time. What's worrying you?
Thanks, Kerry.
No worries. I think I explained it pretty well. It's hard to tell. He needs this treatment, but I wonder if it's what he wants.
So what do you want to do, Unc?
I just want to go home.
I understand that you're all very committed to Jack's care and you're doing all you can to help him. But he's away from his people and his country. This is a strange place for him. He wants to go back to his country. He wants to go home.
I'm sure it must be difficult for him.
We need to make sure he's aware of the consequences of that decision.
If he doesn't have dialysis, he'll suffer from terrible symptoms like headaches, chest pains from fluid around the heart, shortness of breath from fluid in his lungs, nausea and vomiting.
We can't sit back and let him make the wrong choice.
Yeah, I agree. I think we need to be really clear with him what would happen if he doesn't receive treatment.
With dialysis, he'll feel a lot better and have a better quality of life.
Maybe he doesn't want to extend his life, and we have to respect his choice and his cultural beliefs.
We could look at satellite dialysis, where he comes in a few times a week.
Yes, but my concern is he may not come in.
I believe that spiritually, he knows that he isn't going to live much longer. He's worried about his wern, his spirit, and that's why he wants to go home and be with his people.
The connection you have with your country, that's your spirit. That's where you come from. I want to go home. I want to die in my hot country.
Despite all our knowledge and understanding of how Mr. Barry's treatment can sustain and improve his life, we still need to consider what he wants. I think we all agree that he's entitled to choose according to his cultural beliefs and be with his family.
And know that we support his choice.
We also need to discuss with him what options are available and ensure he understands what would happen if he didn't have the treatment.
He might consider satellite dialysis if his family was there to support him.
Yeah, he might.
Could I organise a meeting with Mr. Barry and the team after the morning round tomorrow, about 9 a.m?
Yeah, it's fine with me.
Yeah, me too.
Mick, would you mind checking with Mr. Barry that that's okay with him?
Yeah, no
Excuse
problem.
me, everybody, I have to get going.
Thank you, Annie. Thank you, everyone. Peter, I'll give you a call after the meeting tomorrow and let you know how the conversation went.
I look forward to finding out how it all goes.
Mick, can we chat on the way back to the ward?
Yeah, sure. Thank you,
I'd like to
Kerry.
know more about that region. I'm not very familiar with it and what kind of stuff they have.
Okay. So what are your thoughts after seeing that?
One of my biggest things about any kind of care with people is, well, we don't even realize our own bias. It's so invisible because it's who we are. So it's really, I've been around the world a lot. I was a midwife, home birth for a long time. And it's exactly the same. It's the honor of helping with the transition in or out. But, and a bunch of deaths I've been present for, and it's always me holding space and listening is directly relates to how much I can let go of my own bias, or something like that I was going to say. And just seeing, the intention is love, the care, so much of what we would want for ourselves or our own family or our own friends. It's so challenging, like what the lady up there was saying about her mother. It just takes so much courage to drop that and be present and ask what would the best choice be. And it's just the bias thing is so...
It's so easy to get to buy into seeing it challenging your own side of things and not actually being able to see it from the perspective of the other person and trying to look behind the behaviour.
And we've been trained, even in the training and just the culture of being an American or being a woman or being in my classification or my family or my, whatever roles that I know. It's all layers that I have to be able to see through. So it was a great example of that.
Certainly it's very interesting. A lot of the things that were going wrong with the way that the team was trying to manage the gentleman were because they were coming from the perspective of what we're offering is the best possible thing that we can, and it was potentially the best possible treatment, but it got muddied because of the cultural considerations and because they really weren't keeping in mind that very important thing of patient-centred care, of asking the patient what he wanted. And I think also without Mick, the Aboriginal liaison officer, things would have been quite challenging for them because he was able to act as that go-between. Now, I noticed that Mick called Mr. Barry Unc quite a few times, which is a term of respect. Aunties and uncles in Indigenous culture is a term of respect. Same as in Indian culture. Someone of my vintage would be called auntie as a term of respect. I'd be thinking, are we related? No, it's a term of respect. Yes, at the back.
I've worked with a patient who was an old Italian man, so it wasn't comfortable for him having women come in and help him shower and all that kind of stuff. And at the time, we just thought he was being a difficult patient until the family come in and said, no, it's not comfortable for him. He'd prefer a male doctor. And then everything kind of clicked and we went, oh, that explains a lot of everything. And we just, because we haven't been in that situation, we didn't know. But now that Australia is becoming so multicultural and it's more talked about, I think we're able to recognise the things that we wouldn't say 50 years ago, and it's been able to change and adapt our practice to be more understanding. Like the Aboriginal liaison, if he wasn't there, that poor man, who knows how he would have ended up, because A, he didn't understand what they were doing, and B, it wasn't what he wanted. It wasn't, if it had been in Port Hedland, he probably would have been okay with it because his family could have come and visited, but he was isolated, he was alone, he was frightened, and he had no idea about what was going on really, so.
And that's a great insight that you're giving us, in that he probably, in his community, didn't live in conditions that were anything like the hospital setting. So it would have been really quite a cultural shock for him to be down in Perth. But I also think you raised a really super important point in that the Italian gentleman picked up the label of difficult. And there's probably nothing worse than for someone to be labelled as difficult going through healthcare, because it tends to get handed on shift after shift, and that really does colour people's perceptions.
Do you have access to like the Aboriginal liaison as such, like in hospitals?
Yes, part of accreditation.
Not everyone's going to have a good understanding of that. So
No,
you
no.
have that access.
No, pretty much all the tertiary hospitals will have Aboriginal liaison, and a lot of the smaller hospitals as well. It's part of the patient's rights to be able to access an interpreter, and that can include Indigenous languages. And the Aboriginal liaison people, you might have a volunteer person, but you might have someone that's actually paid on staff. Yeah. When in doubt, I always find it's really good advice to ask the social worker, because they're very helpful about those sorts of things. Make friends with your social workers.
Sorry. I think she did raise a really important point about the male and female, because that extends to my religion as well. So, like for Muslims, like a male and a female have different roles, and I guess if it's a male doctor and a female patient, it can be a bit. There's like lines there. There's like a.
Yeah.
I guess because obviously there's this need for a woman to be modest and like, you know, she has her own personal space and her own. So always consent is a really big thing for doctors and nurses as well to do. So if you're gonna be giving a shower or doing something personal like that, you'd have to have that consent before anything.
Yeah. And I think that's an excellent point that you're giving us. In terms of certainly in the hospital setting, you might have the consultant coming around doing their ward rounds with half a dozen medical students in tow, and just sort of assume that it's perfectly okay to do an examination of someone that might find that that's actually culturally quite offensive. And because of the power balance and the way things work in healthcare, may feel very uncomfortable about speaking up. So thank you, that's really excellent.
I think informed consent is really important as well. Like they didn't explain to him his options until he became difficult, I guess. So I'm a big advocate for informed consent, not just consent in general. You need to know all your options. And I'm originally from the top end, so I know in Darwin at least they have people getting bush tucker for the Aboriginal people in the hospital, so they'll get kangaroo tails, they'll get native plants and that for their diets. So I don't know what they have here in Perth, but yeah, that's what they have in Darwin. They have their native foods.
Well, I worked for a number of years at Sir Charles Gardner, and they actually do have bush tucker on the menu, so yeah, you can get the kangaroo. And obviously it's there because of clients who would prefer to eat that bush tucker. Though I believe it's really, really healthy stuff, so.
I know that we have an elderly female friend that's in hospital, and she had a male nurse ask her to do like bed bath her. She felt too awkward to say no because she was embarrassed, she didn't want to offend him. So I think it's very important to have someone of the same gender to ask, and if a male or female can bath them, to write on the form. Because she told my dad later on, because my dad's one of her closest friends, and he's like, "It wasn't okay." She's like, "No, it was very awkward. I didn't know what I should do. I didn't know if I could talk. It was a very awkward experience and very embarrassing." And so I think it's always good to get informed and like to write down if it's appropriate, because in her culture she's just a normal English woman, and it was just very embarrassing, and she felt like disrespectful a little bit. And also my sister was up north in a teaching community, Aboriginal community, a remote one, and she learned a lot about their foods and stuff. Like they don't eat the same like what we typically would eat, like steak and mash, and they had a lot of different foods. And one of the Aboriginal elders went to hospital and was very respectful, and the nurses in the hospital were very respectful towards the elder. Like they gave him all the respect that he deserved, and they understood the culture. So it's very important if you don't understand culture when someone comes in to research it. My sister had to learn a lot of things. She couldn't go into the Aboriginal homes without her assistant, who's Aboriginal, shows respect, and when elders come, don't give eye contact and all the simple things you need to learn. And that she, when they had certain rituals they had to do, that kids wouldn't be in class because they had certain things. So that was similar to the healthcare system, that said Aboriginal cultures and any culture to learn about it before making an opinion, because before she thought it was a dead culture, and it's not at all up there, and she was very surprised because down here it's a bit more laid back. But yeah, so that's what I think.
And how did she learn?
She had before going up, she got given a pamphlet, and then when she got there, she had a female elder that came up. She actually got given a skin name. She loved learning culture, and she learned a lot of books about it. But one of the elders showed her around the community. When she left bunk beds and stuff to the kids, because their homes were different. Like they had sharing mattresses or sharing beds for 3 kids, and but she had a lot of people helping her. She had one of the teachers was part Aboriginal. He was from down in Albany, so he helped her showed her how to speak Wajari and stuff like that, all the different names. And because half the kids, she was teaching kindy and year 1. She had kindy, pre-primary and year 1 class. So most kids didn't speak English. They had very broken English, so she had to learn Aboriginal, had all her signs on the walls would have Aboriginal words as well as English, as well as she had 3 languages in the classroom. And so she learnt by pamphlets. Also the people in the community were very helpful. Some Aboriginals weren't that helpful though, because they didn't want pushing our culture, they said it was, because they didn't want most kids in the upper cultures actually leave and don't come back. And that's what they hated. But yeah, she learnt by Aboriginals, elders, and they were very helpful as long as you show respect.
Yeah, and it's that thing that respect is a two-way street. Yeah.
Because she showed respect, they showed respect, and they blessed her house and did all the rituals they would normally do to Aboriginal coming into the community. So it's just showing respect and understanding that they're not the same. Everyone is unique in their own way, and we all have different cultures. My sister's a Christian, and going into that community, she couldn't bestow her own beliefs on the kids. She had to let them accept what they would have normally. Because normally on Sunday she'll go to church, and some of them in the community go to church, but some obviously have their own beliefs.
I was just going to say, following on from the informed consent thing, they sort of did it in that scenario. It would be nice to hear him put it in his own words, what he thought was happening to him. So the liaison officer did advocate for him and spoke for him, but if that situation wasn't there and there wasn't an advocate for him, it'd be nice for the nurse to have asked him, now what I've explained, can you put it in your own words? Then that your way, you're sort of making sure that the message was got across, and that there's that two-way street between them. And just in regards to Indigenous cultures, because that sort of is the main culture that we learn from. And one Indigenous person is not the same as the next Indigenous person. It's always got to be careful of that, because I know a guest speaker who came in shared a story with me that he went to hospital, and because he was Aboriginal, they put him in a room with another Aboriginal person, thinking that they would be able to bond and have, but they actually were from conflicting, I don't know if it's tribes, I don't know the actual terminology, but just be careful not to pigeonhole that one Aboriginal person is the same as the next, because they actually weren't allowed to look at each other or speak to each other. So
yeah, it sounds like skin group.
Yeah.
They have particular rules and regulations. Yes. It is complex, isn't it? Yeah. But I think what you as a group are highlighting is that it's very important to try and get a deeper understanding of another culture, and from understanding comes respect. And it's also important that we don't just assume that our medical model is the best possible thing that we can do, that it's not necessarily something that's going to represent what another culture would see as best practice and a best death.
I just wanted to tell us, I used to work in a aged care home, and there was only one Indigenous woman in the facility, and she was actually treated abhorrently by the care staff there. Among the care staff, it was really multicultural, so we had carers from all over the world. She was labelled as difficult. She was a bit cantankerous. She had, end-stage renal failure, multiple amputations, but she was actually a really lovely woman, and I was just appalled at the treatment that she received, and she was the only one that was treated that way. So I just wanted to make sure that we're not just, you have to be aware of cultural differences, of course, but you can't excuse that for disrespect and just being treated really badly, to the point where I actually told management and I quit because I could not stand the treatment that this one woman was receiving by all the staff on the care level, on the carers level. The registered nurses, there was only one on at a time, but yeah, it was really horrible to see and really disheartening, because it was racism there, and it was almost like systemic racism coming down. And so I just think it's really important to distinguish between not being aware and where you're crossing the line and it's turning into racism.
Yeah. And I do wonder whether or not that could be classed as bullying as well.
And especially the medication staff, they were just breaking so many rules. Yeah, and just basic nursing rules were just not being followed for this one particular woman.
It sounds like it was a really negative experience.
Yeah, it was. But I'm actually really excited because my next prac is at double year again in East Perth, so I'm really looking forward to that.
Fantastic. I had another question.
For me, I'm Irish, my dad's Irish. My dad was treated in originally was run completely by nuns, the hospital he was in. So my dad grew up in Southern Ireland, predominantly Catholic. We all went to church every Sunday. Then, because of all different things happening, abuse in the church, he lost complete respect and basically was just had no religion. And when he was in hospital, he was only in for a couple of days, but he had like a chaplain come and visit him, and he was like, "Really sorry, don't mean to be rude, but I'm good, thanks." And the guy left the room again, and we were like, "Oh my God, that's so rude." And he's like, "I don't want to waste his time." He's like, "I know it's a Catholic hospital and I'm a Catholic guy," but he was like, "I don't need his input at the moment." So I thought that was quite interesting, that it's just presumed that because that's our kind of label, that's what we would have wanted. So yeah, I was supposed to have been asked in advance, would you like chaplaincy consultation if there's someone about? He could have said no, and it would have saved that kind of awkward exchange.
More respectful.
Yeah. So.
But it also highlights the point that you might not want pastoral care services at that point, but you might change your mind later on, in which case the door should remain open.
Yeah, like after he passed away, my mum took full advantage because I think she needed it, but he didn't feel the need at the time. So
we had another couple of questions. Comments?
In regards to sort of like what she was saying, like aesthetically, being a younger person, I've had a few patients on my last prac, and it's kind of brought up a few things about, because it was in theatre, they had pretty like heavy duty surgeries and things to sort of prolong their life. It made me realise I would never want to go down that track. If that was my lot, that's my lot, and I would prefer to have the bit of time that I had to sort of spend with my family and my son and my partner. And I think if I didn't have the chance to say that, a lot of people would assume that as a young person that, and I don't really have any like religion or anything, that I would want all of those things done. But I think until you see them or you think about them, you don't really consider it. And I would be so disappointed if I had that taken away from me and had all that stuff done because I wasn't in that position. So I think that's also something we always consider older people, but I've had a few younger patients that were like terminally ill, and it can happen quite suddenly. We need to consider what they might want as well. They don't always want all of those extra things put in place. Maybe they just want to be let go, and yeah.
Definitely not a one size fits all.
Yeah.
With all the technology and all the medical advances, we just assume that everyone wants to live longer, yes, or have that quality of life without taking into consideration that every one of us are different. Also, I think that with all that technology and all that advantage, we forget sometimes the basic things as a human being, and go back to basics and be human again, considering the necessities of the other person like if were mine. What is important to me, probably, or really it will be important for the other person. Family, food, environment, friends, all those kind of things. And with Australia or around the world, everything is going to be so multicultural really soon. We get into the fault of stereotype people for color, culture, or beliefs, which is responded to lack of respect to each other. I think we just have to go back to basics and put ourselves in the shoes of the other person and go back and say just respect, which it will involve all those kind of things.
Yeah. I mean, in my experience, most people are good if they're allowed to be. Okay. Having difficult conversations. We'll just quickly run over this before I introduce our first guest speaker for the morning. So one framework that can be used for having around difficult conversations is one called the Spikes Protocol. So that stands for setting, perception, invitation, knowledge, emotions, strategy and summary. So that's setting up to deliver bad news and have difficult conversations, making sure that you're in a setting that is a bit private, that you're not about to be interrupted, that if you've got your phone with you, that the phone's switched to silent. Just making sure that you're there and you've got the time for the person. Assessing the person's perception of what's happening. So what's going on, what do they think might be happening? Because you might be coming at it from very, very different angles. So asking the person what it is that they perceive to be going on for them. So that might be me saying, okay, so can you tell me a bit about the treatment that you've been having? What's your understanding of what it is that you're in the hospital for? Getting their invitation to talk about what's going on. Do you want me to give you a lot of information? Do you want me to give you some information now? Do you want me to get technical about all the treatment alternatives that there are? Explore those for you? Or would you just like some basic knowledge, give you a chance to think about things and then come back to it? Giving knowledge and information to the patient. How many of you have been present when someone's been having a conversation with a patient that involves jargon? Yeah. It's like a secret language, isn't it? Yeah. So making sure that the language that you're using is clear, understandable, and is pitched at their level of understanding. You've possibly given that person the worst news that they're ever going to hear. So they really deserve you to be present for that and be empathic and empathetic about the fact that it is awful news and that it's not just impacting on them, but it's impacting on you as well, because you're going to feel terrible having this conversation with the person. So acknowledging that their emotions are very, very real, that they're probably feeling quite shocked, that you might need to come back and talk to them more, and just being real. And giving them a summary and a bit of a strategy about what's going to be happening next. So, okay, this is what we've gone over today. You'll probably have some more questions that we can revisit in a while. What I'll do next is, and give them that, or we've talked about your treatment options, you've decided that you wanted to do this, so what I'll do next is set up these appointments for you. Make sense? I've gone over that quite quickly, but we will be doing a live acted scenario that shows somebody delivering some bad news. But what we might do now is introduce our guest speaker. Okay, so we're very fortunate this morning to have a guest speaker from the WA Cancer and Palliative Care Network. and that's the very knowledgeable Kim Grieve. Kim's going to come and talk to us today about advanced care planning and advanced directives, so please make him welcome.
It was really interesting hearing the conversations earlier, because I think what I feed into now actually follows on that quite nicely. So there's a couple of comments that I'm definitely going to draw on down the track. So I work for the WA Cancer and Palliative Care Network. My background is nursing. I've been involved now in advanced care planning since 2009, so that's 7 years. And just to start off with, I've got this a cute little video clip that was made by Victorian Health, and it actually summarises everything I'm going to talk about in about 3 minutes. So what's advanced care planning? So advanced care planning is simply having a conversation with those that are close to us about the things that are important, our worries, our fears, particularly around the care that we'd like to receive at a time when we can't make decisions for ourselves. And ideally including those people that are caring for us so they can be involved in those decisions as well. And also thinking about, okay, what information do I need to make an informed decision about my care, and therefore who I should therefore include within that conversation. Now, having the conversation at today's session, if nothing else, remembering that the conversation is probably the best thing that you can probably remember out of my session this morning. But having a conversation alone is not enough, because I can sit here and talk to you and let you know about what's important to me and what sort of care I would like to receive. But once we all go away from this room, who's going to remember exactly what I've told you and then later on? So therefore, it's actually ideally best to document and formally record those wishes, and then they can be included in handover, and family can remember them later, because conversations get lost over time. The thing about advanced care planning is there's a lot of misconceptions. A lot of people think about having the conversation, thinking about our care in the future is only for the old, only for those people that are dying, and not for the young. And this little video clip summarises the concept of advanced care planning for a younger person who has faced the reality that she's going to die.
My name is Lisa Sinopoli. I'm 41. I have 2 children, 2 boys, aged 10 and 15. I have congestive heart failure, staph endocarditis. I've had strokes and a heart attack, and I don't have long to live. Every day is a new day, and just don't know when time's up, so it's just day by day. I learnt about advanced care planning when I had my stroke 2 years ago. I was told about advanced care planning by someone at the hospital. Respecting patient choices was introduced to me. So I thought about being rushed to hospital after a heart attack, laying in a bed and having tubes put in me. Would I want my children to see me laying in a bed where I can't hear them, communicate to them or anything, and them looking at me and wondering every day, is she going to come out of this? Is she going to wake up? And seeing me with tubes and not able to even lift my hands or tell them I love them or anything. Or are they going to remember me being the fun mum who's crazy or silly and then I'm gone? Which I thought would be much nicer because the kids know the truth about my health. They know I'm unwell. Then I thought of my mum, and I'm a mum, and no mum wants their child to go, but unfortunately circumstances are different for everybody, and you know, nobody wants their children to go, but life is the way it is. And I thought, I don't want anyone to have to make a decision to switch my machine off. So this is my life, this is my body, and I want everyone to remember me as the person I am, who has been sick for so long, but is still fighting to go on because of the will to live for as long as I can and live day by day. And I look at life differently, of course, because we're all dying, but I've got a prognosis, well, I don't anymore, but it's day by day, but we're all dying, so let's enjoy our life. And having an advanced care planning has been the most liberating thing I've ever done, because I know that I have put down that I don't want any of these tubes. No resus, refusal of treatment for everything. I have chosen to have nothing done, because when I go, no one has to choose to turn my machine off and live with that for the rest of their life, that they had to choose to turn it off.
Now, about 85% of Australians are likely to die from an expected death. So that means only about 15% of us will die unexpectedly. So therefore, potentially a large cohort of us should actually be able to have these conversations and plan ahead. Of course, there will be some of that 85% will have cognitive impairment, like dementia, for example, and won't be able to participate. But technically speaking, a large number of us should actually be able to have these conversations because our death is expected. So why should we do advanced care planning? So when we look at the why, we need to look at the evidence. Now, there is actually, advanced care planning is clearly underpinned by lots of evidence. It's actually underpinned by level 2 evidence, which basically means it has been involved in at least one randomised controlled trial. It's underpinned by legislation, it's endorsed by our professional bodies, and is also part of our accreditation standards. So this evidence comes from a randomised controlled trial in 2010 in Victoria, where they have shown that advanced care planning actually improves end-of-life care, improves patient and family satisfaction, reduces stress, anxiety, depression in surviving relatives, and also reduces the stress and anxiety in care staff. And for me, that makes sense. So if you're caring for me, and I have told you exactly what I want around the care that I like to receive, then you don't have to worry about what it is that I want. You don't have to worry about, do I transfer Kim to ICU in the middle of the night? Do I send him to hospital? Should I put a peg tube in? Should I resuscitate him? Should I give him an NFR order? You don't have to worry about all those complications. You can just get on being there, being by me and giving me comfort and care and the dignity that I respect. And that's the same for the family as well. And also reduces the anxiety of the the family as well after death, because therefore they know they've done the right thing, and they also know that the care that their loved one has received has actually been what they wanted. Now, conversations around this obviously are not easy, and can be quite difficult. I've actually now just going through some elements of difficult conversations around advanced care planning, and I've also included there the reference and the web link, so you can actually have a look at it later. So one of the first things is reluctance to acknowledge impending mortality. The reality is that a lot of people don't feel comfortable in talking about death. It's a big taboo in many cultures, more than others. And quite often we don't like talking about death, because if we talk about death and we have to think about death, and we think about death and we worry about that actually we might die and therefore become highly anxious. Perceived irrelevance. The fact that we're too healthy, nothing wrong with me, why do I need to think about it now? I'm young, I just think about going to nightclubs on a weekend, going on holidays, why should I think about it? Technology will solve my problems when the time comes. Research and technology is advancing all the time. Issues of timing. Now, evidence has shown that prognostic indications of death can sometimes be inaccurate. How many times we've seen when someone has been told they've been given 3 months to live and then they're still around 2.5 years later. So actually therefore the timing for advanced care planning can be difficult because we actually don't know when the right time to have the conversation because we've made an assumption that they're going to die in 3 months and they're still around. Diffusion of responsibility. Also, evidence shows that we as patients, consumers, want to have these conversations. We want to actually think about them, plan them and talk about them. But quite often GPs, so we're waiting for the GP to initiate the conversation, the GP is waiting for us to initiate the conversation, and the GP is also waiting for the specialist to say to them, yay, it's time to have that conversation, or it's appropriate to have that conversation. Limitations of surrogate decision makers. Quite often there's a lot of discordance between what we want, what we think is important, and what our family also think about as what is important. That's even more so why it's important to have the conversation so you can make your attitudes, views, worries and beliefs clear, because otherwise they may be making an assumption of what they think it is that you would have liked or not liked. Ambiguous, inconsistent or poorly recorded wishes. When it comes to documenting our wishes, and we'll look at that down the track, sometimes they could be poorly recorded, or people have actually documented things that are unrealistic. One of the biggest things we find is people complete them and they don't sign them, or the fact that people complete them and they're locked away in a safe, they don't want to share them. So quite often people feel quite vulnerable and intimidated about a document that's legally based, because they feel that when they complete an advanced health directive or enduring power guardianship or advanced care plan, which we'll look down further, that they're tied into that for life. They worry that can they change that or revoke those wishes before they lose capacity, and people actually feel very intimidated when it comes to anything that involves a legal issue. Now, before having a conversation, when people talk to me or ring me up or wanting to discuss their care and their future, one of the first things I say to them is, why now? Why are you thinking about discussing and planning? And for each of us, I say we have a different story. And that story, then what happens to us, will then tailor that conversation that we have. So each of us are very different, and our story is based on our experience, our life, our life experience, our values, perceptions around death. For example, people may have seen people have a good death, and therefore be quite clear about things that they like or not like, or people may have been exposed to someone who's had a, shall we say, a horrific death or bad experience, and therefore can be quite worried, or as a result of that be quite clear about the things they do and don't want. So one of the first things I ask them is, what's worrying you? I know it may sound simple, and how is your current health? So we're trying to get a baseline as to where to tailor that conversation. Then look at what makes life meaningful for them. What's important? So what makes life meaningful for you? It could be, for a lot of us, we quite value holidays, weekends, going out for dinner. Now, if you're suddenly faced with a life-limiting illness and you know that you're likely to die in the next 3 to 6 months, suddenly that skews or changes that perception about suddenly what's important to you as an individual and what's is important for your family, for example. What activities do you enjoy? Are there any special events that you're looking forward to? Now, I love gardening, but if I've suddenly got lung cancer and I'm short of breath and I can't get out in the garden, is just sitting there looking at the garden good enough for me? Does that give me quality of life? So the view and perception that I have will be very different for each of you, because we are all very different and individual. And I put religious and personal beliefs because, as we know, we live in quite a multicultural society. Now, we cannot be aware of every possible practice and belief that people may have, but we can do one thing. We can ask, what's important to you? How would you like your belief system to be incorporated in your care? Because at the end of the day, we are in the business of caring for them, so we want to tailor that care and respectful for them and not make cultural assumptions. Goals of care. So what is our goal? Is our primary goal curative, restorative? Is it palliative? Or could it be all of those? For example, if I know I have a life-limiting illness, for example, lung cancer or pancreatic cancer, for example, I might have the view that, yes, I want to have active treatment, chemotherapy, radiotherapy, with the hope of a cure or a hope of a remission to extend my life or give me better quality. But the realisation is that at some point I might realise that's not going to work, and then I might actually want to have a more of a palliative approach and have my comfort and dignity respected. Now, palliative care in the past, the model for palliative care was very much end of life, so the last days or hours of life, where we would either put people in a palliative care unit, a hospital bed, a hospice, give them painkillers like morphine and hope that their death is comfortable and pain-free. Now we have a much more proactive approach with palliative care, where we now believe that palliative care people should actually be referred to palliative care right from the diagnosis of a life-limiting illness. So right now, if I've just been diagnosed with a life-limiting illness, if I was referred to palliative care even before I'm symptomatic, then I can have the conversations and have a plan in place. I can talk to them about my worries and fears. I can talk to them about the treatments that are possible. I'm on their radar, so they're going to keep an eye out for me. I know who to go to when it's 3 in the morning and I'm in a great deal of pain, and I know what resources there are, rather than being left there in a situation where people don't know who to go to and probably most likely end up in the emergency department. I think the next point leads into the conversation that I heard earlier, is before going into the conversation and talking about treatment and care options and futility, etc., is actually ask people how much information do they want to receive? What do they feel comfortable in hearing and talking about, particularly family? For example, if I was to say to someone, all right, you've got pancreatic cancer, you're likely to die in 3 months, you're going to have your clotting or altered, you're going to bleed everywhere, have horrible ascites and probably have a great deal of pain. That's probably not what they want to hear right then. As soon as they've been diagnosed with a life-limiting condition, that can be quite traumatic, and then you're overwhelming them with too much information besides frightening the life out of them. So therefore, what do you feel comfortable in talking about right now? Maybe we can tailor the conversations and have a series of conversations, so not answer all the questions in one go. And family members, how much information do they need and what do they feel comfortable? So you actually can tailor the conversation to their needs. Now, futility. Now, there's a lot of evidence to suggest that futility and quality of life are directly linked. So the way we see quality of life is very different. Now, there's an old saying that pain is what the patient says it is. I say that quality of life is what the patient says it is, or what we say it is. So, for example, my perception of quality of life will be very different to your perception of quality of life, and no answer is right or wrong. We are all just very different. So when it comes to treatment and futility of that treatment, it's very much we view that treatment in relation to our quality of life. So, for example, if I'm faced with chemotherapy for 3 months and it may only extend my life for 1 month, now in my schema of my quality of life, is that treatment going to improve my quality of life or not? So if I think that is, then therefore that adds value, so therefore I may consider that treatment not futile. If I look at that treatment and I consider to myself, no, that's not going to add value to my life, then therefore, and improve my quality of life, therefore I could view that treatment as being futile. So futile is very much a subjective value for each of us, and it's very much a perception as to how we view it. It can also be a contrast to clinical futility, which is what the health professional may see that treatment. So, for example, the health professional may consider that chemo as not being clinical futile because it has an outcome, I'm going to extend your life for a month, which they may think is worthwhile, but from a personal perspective, it's very much a subjective outlook. How can we approach achieving a balance between living longer and maintaining quality of life? I think I've already touched on quality of life. Then we're thinking of length of life. Now that once again is very different. If you've got someone who's young, and someone just talked a minute ago about having, being young and having children and family, therefore their view on quality of life and length of life might be quite different. They actually may want to forgo quality for quantity to have time with their children, or they actually, once again, quality may be more important. Similarly, if someone's very old, for example, and they're approaching end of life, maybe quality is far more important to them than quantity. Once again, there's no right or wrong answer. It's very much an individual choice. Now, I've just got one other little video for talking about, this little video clip is once again in Victoria. It's an intensivist, so it's a professor that works in intensive care, and he talks about what the difference between what doctors want to do in trying to help people and the perceptions that are of people that actually they think the doctors know what is it they want.
About 80% of people at the end of their life are in a position where they can't make their own decisions. I'm Associate Professor Charlie Cork and I'm a specialist in intensive care medicine. Some people will say that my family know what to do or my doctor will know what to do, and unfortunately they're wrong. When a family's got an advanced care plan and knows what their relative want, it's enormously easier for the family because they haven't got all the responsibility of making these what they see as impossible decisions. And it makes it ever so much easier for the doctors because doctors are trying to do the right thing. They just need to know what it is. I think advanced care planning, in a nutshell, is three important things. It's about thinking about it, and just thinking about it starts the process happening. Talking about it to your family, talking about it to your doctor. The third thing is picking a great decision maker. Because 80% of us, right at the end, will not be able to make our decisions. Just at the end of life, the way the process goes, you're not able to make decisions, and decisions need to be made. And a great decision maker is able to talk to the family, talk to the doctors, make a decision, make the right decision for you, and to feel comfortable about it. And it makes the whole process so straightforward, so controlled, and so sensible. And that's really, really good.
So I've talked about the conversation, and probably by now you've realised the conversation is pretty important. And also described that the conversation on its own is often not enough. It's actually really important to record those wishes so people are aware of them down the track. As I've said, then they can be incorporated into handover, and so health professionals and family and the patients are all on the same page, to use a similar term that's been used quite a lot, around the care that we want. Now, the three things I'm going to talk about. So we've got the Advanced Health Directive, Enduring Power Guardianship, and Advanced Care Plan. The Advanced Health Directive now have been around since 2010, so it's 6 years. It's a statutory document, therefore it means it's been passed through legislation, it's embedded in the Guardianship Administration Act, and the form is part of the Guardianship Administration regulations. The Advanced Health Directive enables us to record formally treatment that we'd like or not like to receive in advance of a time when we can't make those decisions for ourselves. So we make the Advanced Health Directive while we have capacity, and it comes into operation when we've lost capacity, in other words, when we can't make those decisions for ourselves. And Advanced Health Directive records treatment decisions only, so in other words, treatment that I'm happy to receive, that I consent to, and treatment that I don't want to receive, in other words, treatment that I refuse consent to. So to give an example of some things that we can put in our Advanced Health Directive, for example, I could write, if I have any disease, illness or injury, I'm unable to recognise family and friends, I'm in a great deal of pain, my condition is unlikely to recover, I refuse consent to active treatment, I consent to palliative care. So what you're saying in that situation is you recognise that when your condition is unlikely to recover, and you have poor quality of life, you actually want your focus to be on palliative care, comfort and dignity rather than active treatment. Another example could be if I have dementia and I'm unable to recognise family and friends, unable to feed myself, I refuse consent to any form of feeding, I consent to palliative care. So what I'm saying in that situation, if I'm in dementia, I'm in an aged care facility, I can't feed myself, I actually don't want anyone else to give me any food and fluids, I actually just want the natural process to go on until death comes along, but I do want good comfort care and dignity and pain relief and just be well managed and from a palliative care perspective. From a health professional perspective, that means we must follow those treatment decisions. So in the first one, we wouldn't be doing CPR, we wouldn't be transferring them to ICU, we wouldn't be giving any form of active treatment. And the second scenario basically means we wouldn't be able to feed them. And we can do everything else, but we wouldn't be able to give them food and fluids. Advanced health directives, no one can override your advanced health directive, no family, no doctor, no friend, no nurse. The only body that can override your advanced health directive is the court, and that's the state administered tribunal. It's the only body. Now, just going back a step, advanced health directives aren't for everyone, and not everyone should be encouraged or made to have an advanced health directive. It's very much a personal choice. Advanced health directive is very powerful if you're clear around the treatment you like or not like, and that could be based on your experience around seeing someone who has had treatment that's worked well and they've actually been cared for quite well, or on the contrast where you've seen treatment hasn't gone well and you've seen people suffering, and therefore gives you a bit of an idea about the sort of care that you'd like or not like to receive. Or maybe even someone who actually already has a life-limiting condition and therefore already has a sense of their disease trajectory and therefore knows what's happening in the future, so therefore they can plan ahead. When I spoke to my mum about that, she goes, I'm 83, I'm on no medication, I'm very well, she's probably fitter than me. And she goes, well, how do I know what's going to happen to me? I don't have a crystal ball. So I said, well, Mum, maybe right now an advanced health directive isn't right for you. So maybe we can look at other forms like an enduring power of guardianship. And then you can reconsider and come back to an advanced health directive in the future, when you have a more clear idea about the things that you do and don't want. Now, an advanced care plan is, and you've got an example in the green booklet, Advanced Care Planning Guide Patients. You're actually the first ones to get version 2, which has just come hot off the press with our new form. We've made some adaptations, and now you can tell version 2 because you've got a lovely gentleman with his pyjamas rather than ladies throwing the ball around, which is quite nice. So Advanced Care Plan is not a formal tool or legal tool like the Advanced Health Directive, but it's a way of recording that conversation. So if you have a conversation now, we can record it in Advanced Care Plan. Maybe a week or two later, you have another conversation, you can record it again, so you can have a record of that conversation, an ongoing conversation. It's also a way of recording people's wishes around care that is not necessarily treatment-based, or care that they may not be able to put in their Advanced Health Directive. For example, what I mean is I'm more than just giving treatment. So I'm more than whether you give me an antibiotic, more than you put me into ICU or give me a drip. There are lots of other things about me as an individual and about you as an individual that you would like your health professionals to know. For example, letting them know that you're vegan, that you're celiac, that you hate bird songs, that you like pink, you don't like blue, you like your feet being massaged, you don't like your feet being massaged. You like particular talcum powder and particular aftershave or perfume brings you out in a rash. Who would you like to be around you? Would you like your dog or your cat or someone close to be with you at the time of death? Or is there any particular one that you don't particularly want to be around you? Talking about that religious perspective before, you might want to document something like that. For example, make it quite clear around who you don't want. So that's a way of describing things, because quite often we rely on family and friends to know all those things about us, but at a time when they are already highly strung, already under the pump in terms of trying to work out what's best for you, this is a way you can actually describe those care and wishes that you want for the people that are involved in your care. Enduring Power Guardianship, like the Advanced Health Directive, has been around since 2010, embedded in the Guardianship Administration Act, is how you can appoint your substitute decision maker for personal, lifestyle and treatment decisions. Has nothing to do with money. You may have heard of Enduring Power of Attorney. That's where you can appoint someone who can manage your financial affairs. Enduring Power Guardianship is where you can appoint someone to make those, as I said, personal, lifestyle and treatment decisions. So they can decide what aged care facility you go to, who can come and visit you, and what treatment you want. So they can actually consent and refuse consent to treatment on your behalf. So they have that authority. Once again, you can only make enduring power guardianship while you have capacity, and it comes into operation when you lose capacity. You can also give direction to your enduring guardian on the front, so you can say, for example, I want to live be put in an aged care facility north of the river. I'd like to be in Bunbury where I'm near my cousins or my niece or nephew, for example. So you can guide your enduring guardian, but at the end of the day, your enduring guardian will be making those decisions for you. But part of the conversation before appointing someone is appoint someone that you trust and has similar value and belief system, because it's a big ask to ask someone to be your enduring guardian, and it's a big responsibility for them to take that on board as well. Thinking about what we talked about before, when there can be a discordant between our value system and what we want and family members, and therefore that conversation is really important for your enduring guardian to be involved in their conversation so they can be a part of that and know it is what they want to make those decisions when the time comes. I'm going to focus on non-urgent treatment rather than treatment this morning because I know we've got limited time. But on the day-to-day care that we give people, and we give, quite often we give non-urgent treatment, antibiotics, putting a drip in, feeding someone, feeding's a treatment. Now, right now, while we all in this room have capacity, I can simply ask you, can I feed you, can I give you an antibiotic? And you would say yes or no, and that's other words, consent. We as health professionals, as much as some people may still like, or what used to be often done in the past, is we cannot just give treatment and do things as we want, because that's assault. But what happens when you lose capacity, when you no longer can make those decisions for yourself? Someone has to give consent, otherwise, as I've said, we need to have consent to give a treatment. So if you have, and under the law, the person that makes this decision is what we call the person responsible. Can be quite often be quite different to next of kin. Next of kin, by definition, is your closest blood relative, and it may not be the same under the legislation when we look at the hierarchy in a minute as your person responsible. So we now have what we call a treatment hierarchy. This is a hierarchy that health professionals must follow top down every time a treatment decision is required when someone has lost capacity. So the top of the list is, no surprise, is the Advanced Health Directive, because that's what I want, what I've decided, and I have proactively made an anticipatory decision and formalised that in a document, in a legal document. And therefore, health professionals must follow someone's Advanced Health Directive. But if someone hasn't made an Advanced Health Directive, or the Advanced Health Directive doesn't match the scenario that's been presented, then we can cascade down the list. Have they appointed an enduring guardian? And as you remember, the enduring guardian is the person that I could have appointed to make consent and refuse consent to treatment. So therefore, we could go to that enduring guardian and ask them to make the decision. Now, with authority that I've put there is when you appoint someone as your enduring guardian, I can appoint one person to make all decisions, or I could appoint one person to make personal and lifestyle decisions, maybe because they've got a social work background or I feel quite comfortable they fit that role, and I may have appointed another person for treatment decisions. So therefore, not only do we need to look at the enduring guardian, but we need to identify, are they the right enduring guardian for the right decision? Now, maybe we haven't appointed an enduring guardian, or maybe they're not contactable, then we can go down the list. A guardian. A guardian is someone who's been appointed by the state. So if I'm 95 and I've outlived everyone in my family, got no friends, then someone, as I've said, has to give consent. So if I'm in that situation, the State Administrative Tribunal will appoint a guardian, and they will then be responsible to making those decisions. And the guardianship order will clearly state as to what decisions they can make. So maybe a guardianship order hasn't been made, so then we get right down to the next level is spouse and de facto. So if you're married in a de facto relationship, and that includes a same-sex partner, you have the legal right to consent and refuse consent to your treatment for your partner. So you're the person that will be making those decisions for that person when the time comes. Now, if your partner is not available, can't be reached, or maybe you don't have a partner, or maybe your partner has already lost capacity, which can happen, we can then go down the list. So we go down to adult son or daughter. Now, they must be over 18, have capacity, and be in a close relationship. Now, if you have more than one child, that's the right word, we only need as health professionals to go to one child to make a decision. Now, if there's more than one, there's potentially could be conflict. So what I would always encourage in that situation is we have a family case conference, try and get everyone on board. But once again, if there's such severe conflict, we can go to the State Administered Tribunal and they may appoint one of them as a guardian. But we can, technically speaking, only need one to move forward. Now, maybe you don't have children, or they've gone with a spouse on a holiday and they're not contactable, then we go down the list. The next level is parent. For probably a lot of us in the room, it could be appropriate having a parent, but if you're in an aged care facility when they're 95, that moment's probably well and truly past. If you don't have a parent or they're not contactable, then you go down the list of siblings, so it's your brother or sister. Then you could go down to a primary unpaid caregiver. That's not someone from HAC, that's someone who's been identified as your carer, and that's usually someone that's close to you, like a family or a friend that's actually had that designated role. We then go down to anyone in a close relationship, so it's probably your BFF, that you probably catch up with all the time, your chest buddy that you see every Wednesday, maybe your minister or someone from the church that you see have a close relationship with. But if you get right down to the bottom and there's no one, then we go cascade right up to the list to a guardianship where someone would have to be appointed by the state. At the end, someone has to be able to give consent, because once again, health professionals cannot give treatment without consent. So once again, there's a potentiality of conflict. There's conflict from the health professional. An advanced health directive must be able to be translated into clinical practice. So we are in the business of clinical practice, so we must be able to interpret that order as something that we can do clinically. So for example, if I put in my advanced health directive, if I've lost capacity, I'm no good to anyone, stick me out on the freeway, I don't think that we are in the business of putting people on the freeway, so therefore we would deem that as conflict, and therefore we should be going to the State Administrative Tribunal and saying, hey, I don't think we should be putting Kim on the freeway, as much as maybe some people would like to, but we are not in that business, so therefore there's conflict. There could also be conflict from a family member. I don't think Kim would want to be fed. He clearly likes his food. So why would he have said, I don't want to be fed? I'm a bit concerned about that. So the family member could also go to the State Administrative Tribunal. There could also be other conflict around enduring guardians. For example, I don't think Kim's making the decisions in the best interest for his mother as his enduring guardian. I have concerns about that. And then they might come back and say, yes, your concerns are justified, or no, actually, I'm sorry, but we think you're incorrect. He's actually making the right decisions. So what do we do with these directives, this formal documentation that are available, so they can be available? At the end of the day, we want them to be available at point of care. We don't have a register to formally register your advanced health directive or enduring power guardianship, and that's not likely to happen under the current climate of economics. So therefore we need to make them available. So therefore we should inform our family, inform our specialist, inform our GP. I, Kim, have got an advanced health directive, here is a copy of it, so therefore it's available when needed. If you regularly go to a hospital, or you've been to a hospital, for example, I've been to Joondalup Health Campus, therefore I could send them my advanced health directive and they could store it, have it available for the next time I come. But if I've never been there, they're likely to say, thanks very much, it looks good, but send it back to me because we can't store it and keep it because we don't know who you are and you don't have a file. We could let people know where we keep it, so we can let our neighbours know. For example, in our household we have a box in the study which has our will, advanced health directive, enduring power guardianship. Everyone knows where it is, it's all in one box. So if anything untoward happens, people know exactly where to go. Quite often emergency, the ambulance crew look at fridges for some reason. It seems to be quite popular, so you can always stick it on your fridge. But either way, let people know where it's available, so it needs to be available at point of care. You could register with eHealth. Now eHealth is a Commonwealth initiative under Medicare, and now not only can you register in eHealth and let them know who has got a copy of your directive, you can actually upload as a PDF your directive so it's available when it's required. You could also think about a medical alert. Medical alert, actually, if you have a medical alert bracelet and you give them a copy of your directive, they can then actually fax or send off your directive when it's needed. We actually, in your back of your little patient advanced care planning guide for patients, we've given you an advanced health directive alert card. It's a little card that we developed, folds up into a little business card size. You can keep it in your purse or your wallet. I keep my mobile phone case, so I've got it with me in case anything happens today. And so it tells people who you are, who your usual GP is, who has got a copy of your Advanced Health Directive and Enduring Power Guardianship. Ask your age, which I think is very impertinent, but still. It can be actually, the reality is, if you are in a critical situation, people are going to go through your belongings and look who you are, and up pops your Advanced Health Directive Alert card, so you can actually therefore increase the availability of access at point of care. We have, actually before I go into that, the other things that we are doing in WA Health to improve access to point of care, I only heard this week that we've enabled to have a PAS, which is an alert on our electronic system. Now, when you go into a government hospital, we have what we call a patient admission system, and most of the hospitals now in the metropolitan area, for example, have web PAS, and other hospitals in the country areas are moving to web PAS. We've actually now enabled an alert to be put on there, you've actually got an Advanced Health Directive. So for us, that's a double win benefit. For one, we can now start hopefully collecting data around actually how many people actually have an Advanced Health Directive. Before, we actually haven't been able to actually start collecting a lot of data more accurately as to how many people actually have an Advanced Health Directive. So that's one thing. From a client perspective, it also means that there's an alert that you've got one, so you don't have to be constantly bombarded. Have you got an Advanced Health Directive? Have you got an Enduring Power Guardianship? Because they'll know that you've got one. And so we'll be launching that and letting people know about that very soon. Also, on the Advanced Health Directive, we're still in the legal at the moment, but we're also looking at introducing a barcode and a medical record number. Now, why are they significant? A medical record number tells you exactly where that document is filed in your patient notes. That means it's all going to be every hospital, your Advanced Health Directive will be filed in the same place. So it's easily located. And also the barcode is a way, the barcode enables electronically to identify that it is an Advanced Health Directive and also who you are. So hospitals like Fiona Stanley and the New Midland Hospital, they have electronic systems, and not only can go scan it and know it's an Advanced Health Directive, it can scan it and drop it into your electronic record. So that's the other thing that we're working on at the moment. We have a variety of resources available. You've got the Advanced Care Planning Guide for patients and for health professionals. You've also, in your packs, got our guide to preparing an Advanced Health Directive and Advanced Health Directive form. We actually have Advanced Care Planning packs for people when they ring up in the community, and we just send them out. So it's the envelope pack that you've got is an example, and we can quickly send them out to them. We have telephone support line, that's me, and so if people want to ring up advice, since 2011 the number of calls that were received is increased by about 350%. Now we see not only people wanting information and resources, they want to talk about it, and quite often it's people at crisis, so you're also in some ways becoming a counselling service, and people, so it's actually, the demand is actually growing. So it's a resource that you can use later if you've got any other questions. Family members, if people want any of our resources, all our resources are free and we can send them out to them. We live in a multicultural society, so on our website we have information explaining Advanced Health Directives in multiple languages, not only as a PDF but also as an audio file. And now we are working on having the Advanced Care Planning resources, the patient guide, translated into multicultural languages as well as Aboriginal resources. The Advanced Health Directive is part of the Department of Health. The Enduring Power Guardianship and Enduring Power of Attorney is part of the Office of the Public Advocate. So therefore I've given you their information. So if you want further information on Enduring Power Guardianship, Enduring Power of Attorney, then they're the people to give far more greater depth advice than what I can for Advanced Health Directives, and that's our information. So you can be simple as flicking me an email, acp@health, or a telephone call, and we can get back to you. And that's the conclusion. Thank you.